Our speaker today for our workshop is Dr. Crisanti Sardelli. She is Associate Professor of Pharmacology and also obstetrician and gynecologist. So it's your...
Thank you very much. A pleasure to be here. I could finish my talk in 2 minutes by saying that it's bad to be having an RMD, but it's even worse to have it with menopause. So, but we need to explain a little bit why it's important. I have no conflicts of interest to declare. You all know, because you suffer from this, that autoimmune and rheumatological musculoskeletal diseases, RMDs, I'm going to refer to them as RMDs in the future, are significantly higher in women. So there must be an effect of sex hormones that could influence the whole situation, and it's something we know because there is changes during the reproductive life of a woman that we observe, mainly very, very present during pregnancy. It's important to remember that for SLE, 9 women suffer in comparison to 1 man, and in Sjögren's syndrome, it's also in Sjögren's syndrome, and it's 3 to 1 for systemic sclerosis and 3 to 4 to 1 for rheumatoid arthritis. So it's something that impacts women a lot. And estrogen, the primary female sex hormone, appear to play a major role in modulating the immune system. So we have receptors for female sex hormones in all immune cells, and they regulate also in these immune cells the expressions of genes that are involved in inflammation. So basically, one may assume that it's mainly being female and having estrogens and progesterones also, but mainly estrogens in your body is something that might cause inflammation. But moving forward, as I already mentioned, we have different stages in our life. We are children, and then we become premenopausal. I call premenopausal the whole period between having a menstruation and stopping having a menstruation. Then we move on to the perimenopause. I don't need it. They can hear me, I think. Oh, it's okay. I like to move around. I get bored otherwise. Then we have the perimenopause. It's between 2 to 10 years before the final menstruation. And it goes on the year after the final menstruation. And some years later, it depends, between 2 and 5, we might point it. And then the menopause is the period of life in woman. A small period of that is also perimenopause, but the period of life in a woman's life after 12 months after the last menstruation they have. So you are not in menopause unless there has been 12 months from your last period. It's very important to know. Women diagnosed with RMDs frequently experience changes in disease activity after menopause. And we don't know exactly why, but both absence of estrogen and progesterone play a role, but also there is a change in androgen to estrogen ratio that plays a role, because sex hormones behave differently when it comes to immune functions. So when it is normal, when is it normal to become menopausal? Anything between 45 and 55 years of age is supposed to be normal. If you live in a higher income country, the median is 51 years of age. If you come from a lower income country, poorer country, underdeveloped country, it's around 48 years of age. Until recently, we said that, and we have some slides later for primary ovarian insufficiency, we thought that until 40 was okay to have a period. Now we know it is important and imperative for our health to have a period at least once every 3 months until we are 45 years of age. This is very important because, especially for females with RMDs, it's very important because many times they experience other health problems and they end up with a surgically induced or an iatrogenic ovarian function cessation. And this is very important to know that 45 is the timeline until we are not allowed not to have a period. So keep that in mind. And if we become menopausal before this age, we have problems with the cardiovascular system, we have strokes, and we also have cognitive decline, among other things. So it's very important to preserve ovarian function or supplement until this age, at least this age. And this is another thing that brought me in contact with Katie and Nadia and the Greek Society of Menopause. I'm their scientific advisor, one of their scientific advisors. I'm very happy for that. Is that there are many, many symptoms in menopause or perimenopause that are similar between the two conditions, menopause and the RMDs. We have psychosocial changes. We have, and also burden. We have sexual dysfunction in many cases. We have trouble and pain during intercourse due to vaginal dryness, among other things. We have a worsening of quality of life. Okay, here I will put a question mark, but okay. Many of us experience joint pain and stiffness. Not something that it's written in stone, but it happens very, very, we can do something about that. And many, many women have diffuse musculoskeletal pain. All symptoms known to you from your medical conditions. So is it menopause or is it RMDs? Not everybody has an RMD, and not all menopausal women have these symptoms or in the same degree. But it's imperative to talk about it and look at it. It's our hormones, it's our ovaries that are not working anymore, and we believe hormones are the problem. So what are hormones? Hormones are organic substances, chemical substances secreting both in plants and animals and humans that function in regulating the physiological activities of our bodies or of the plant bodies, if I can call it that, and maintaining homeostasis, maintaining the body in a situation, a condition that is normal and allows functioning in the usual way. So the hormones are secreted in minuscule quantities, but they have huge results in our health. They evoke responses from specific organs and specific tissues that have receptors to these chemical molecules. So what do they regulate? They regulate growth, they regulate metabolism, they regulate reproduction and sexual function, and they regulate our moods. So all these things are very, very paramount to our health. And when we are talking about hormones, of course, most of them come from the molecule, the very maligned molecule that we call cholesterol. Cholesterol is not a bad thing. We need it for producing hormones. We get mineralocorticoids, we get glucocorticoids, we get even vitamin D from cholesterol, but we also get our progestogens, which then are metabolized with specific enzymes in the body, first to androstenedione and testosterone. First, we get male hormones, also in female bodies. And then, in women only, these male hormones, they become estrone and estradiol. Estrone is a very, very mild, not so potent estrogen, but basically 17-beta estradiol is the main estrogen during a woman's reproductive phase of life. And we have then 17-beta estradiol, again metabolized to other estrogens, mostly hydroxylated estrogen metabolites. So what happens here? Men are very, very, how to say, they are mostly gifted in this area because basically male hormones, they promote an anti-inflammatory phenotype. Whereas estrogen, they promote sometimes anti-inflammatory phenotypes, but in other cases, they, when you are pregnant, for example, but they promote pro-inflammatory responses when we are in menopause. So, but in general, estrogen in normal quantities, not in pregnancy, they are pro-inflammatory. So men in a way are protected and women are not protected just by being men and women. So this is a fact of life. We don't like it, but that's the way it is. And just to summarize, androgens and progesterone carry immunosuppressive properties. In patients with RMDs, this could be a good thing, okay? But estrogen and prolactin is the main hormone secreted during parturition when you lactate your children during breastfeeding. They modulate the immune response. We will have a small talk later in the day about pregnancy. And they work on B lymphocytes and regulate their maturation and ability to secrete self-reactive antibodies. So they play a role in immunomodulation. But basically, they have the opposite properties than androgen and progesterone. And very important to talk about is also that estrogen and progesterone, but mostly estrogen, also are protective of bone and joint health, which is very important in patients with RMDs. So we have both the immune component, but also the musculoskeletal component that is regulated by these sex hormones. And as we said, women are not gifted in that area. So menopause is the critical intersection. Approximately, now that we live longer, we are mostly, most of us are around halfway through our lives, a little bit later. And we have both aging to fight. We have the natural, normal aging and wear and tear of our bodies. But we also have hormonal changes that we have discussed, have very, very severe effects on our immune response. I will not go in too much in the details, but both monocytes, B cells, T cells, and NK cells, you recognize all these words. These are the small cells of the immune system, the cells that are actually carrying out the function of the immune system. All of these cells, types of immune cells, are regulated and modulated, and their function changes during both premature ovarian insufficiency and also menopause. We have slightly different responses during the two conditions, but I'm going to talk in detail now. What is primary ovarian insufficiency? As I mentioned earlier, until recently, we said until 10, 15 years ago, we believed that it's a condition where menopause occurs before the age of 40. Forget 40, it's 45. Already at 45, below 45, we have a problem with suffering. It becomes a condition, not a normal situation. And when we put the limit at 40, it had a worldwide prevalence of 3.7. Below 45, it's much more. So a substantial number of women lose prematurely their ovarian function. It is a burden a public health burden, and we need to address it. Why does it happen? In most cases, we don't know why. But the more we learn, we believe that there is a genetic component. There is a family inheritance. That's why, as obstetrician gynecologists, we usually ask our patients, when did your mother stop menstruating? But it's not absolute for everybody. We have some chromosome defects, especially in the X chromosome. It's a female condition. But there are some cases that we have also mutations in other genes, not in our sex chromosomes. So there are problems we do not have the answers to yet. We have a peculiar pathogenesis, but we believe there is also an immunologic component there. So it's mostly probable that there is a connection between RMDs and primary ovarian insufficiency. Because we have immune cell alterations that are not extended to all menopausal women. So this population of women losing their ovarian function earlier than expected, there are a special category of patients or women, whatever they believe. So why is it so important for us to talk about this primary ovarian insufficiency? It's because there is a 40% chance of at least one autoimmune condition in these women, and most of them have Hashimoto's disease. I have Hashimoto's disease without primary ovarian insufficiency. SLE, RA, psoriasis, Crohn's disease, polyglandular autoimmune syndrome, and celiac disease. Not so fun things to have. And there is also a strong association with a range of autoimmune disorders. As I said, Hashimoto's disease and autoimmune thyroiditis, 27%. Diabetes mellitus, 2.5%. This is another big issue, around 10 to 12% to 15% in some terrible cases of all populations have diabetes mellitus. So it becomes more complicated if you have other problems too. And these women with primary ovarian insufficiency tend also to have Addison's disease, an autoimmune disease of the epinephrites, an autoimmune polyglandular syndrome, hypophysitis, which changes the whole hormonal status due to the central role hypophysis plays into the endocrine function. And then we might have conditions like hematologic conditions like thrombocytopenia purpura, vitiligo, these white patches some people have, autoimmune hemolytic anemia, another hematologic condition, RA, SLE, primary biliary cirrhosis, a terrible situation to have. It's a deadly disease, and you need a transplantation if it works and if you find a donor to get it, and hepatitis. What does this signify? Just to put it in a nutshell, we need, as obstetrician gynecologists, but also as women with this condition, we need to ask to advocate, you need to advocate for screening for an underlying autoimmune disease and a rheumatologic evaluation in all women with menopause before the age of 45. It is more than 3.7% in all populations. It's below 10% of all women, I would speculate, but it is an important number to have in mind. You need to work for that. You need to advocate as patient organizations. And this is very important for public health because all these conditions, but also the increased risk for cardiovascular diseases, strokes, and any other medical problem, it burdens the healthcare systems worldwide. And it's something we can, if not prevent, mitigate. So these women, they deserve a rheumatologic evaluation, and they need to be guided and counseled to get a screening for an underlying autoimmune disease. So this is an important message of this talk, if there is one. What happens with the RMDs? Just a table I found in a very good and recent review from March 2025, if you have a rheumatoid arthritis, 3:4 to 1 risk of females to males, worse disease outcomes, disability, and quality of life after menopause. So it's not nice to be a rheumatoid arthritis patient and become menopausal. Not good. For psoriatic arthritis, where men and women are equally involved, there is no data available. For SLE, 5:1 up to 9:1 females to males. Here, the news are better. We have improved disease activity. We have decreased frequency and magnitude of flares, at least some good news. In this also very, very bad disease to have, if I can call it that. In Sjogren's syndrome, again, 9:1 females to males. That we don't have data about what menopause does to this condition. In systemic sclerosis, again, improved skin fibrosis, increased risk of developing pulmonary hypertension in patients with limited form of the disease. So in systemic sclerosis, we are going to talk a little bit more about that. We have different types of menopausal effects. So this is an extra point to bear in mind. And in the rest of the autoinflammatory diseases, we have improvement in half of the cases. So in most cases, it's not bad to become menopausal unless you have rheumatoid arthritis, which is also the most common, I guess. So good news, but not so good news in terms of numbers. So when we have menopausal women with problems or menopausal women in an earlier age than we would like to have them, we discuss giving them HRT, hormone replacement therapy. Of course, hormone replacement therapy is not the only effective treatment for postmenopausal or perimenopausal symptoms, but this is the one that is most effective. And if we didn't have all these bad safety concerns, it actually would be the best, the most logical thing to give. Continue to supplement women after menopause with what they are missing, since we believe that is good to have estrogen, progesterone circulating. But no, we are not doing that because of specific safety concerns. However, it's a treatment. So what happens with RMDs? The role of estrogen appears beneficial, but is it okay to use in RMD patients? So the most studied condition is rheumatoid arthritis. And there we have conflicting results. If you use oral contraceptives sometimes, because they are readily available, can be used as a form of HRT, although the dosages are not the indicated ones. And I mention this because in Greece we had a shortage of medications the previous years due to pricing and other stupid problems we have in dealing with medications in Greece. The policies are completely out there, despite what the governments are saying, the last two governments at least. And we also have younger women that might have problems like premenstrual syndrome that we might need to regulate with oral contraceptives. And we also have the need for contraception. We're going to talk about it in the next talk in the afternoon. So we need to look at oral contraceptives too. So the newer formulations with a lower estrogen and higher progestin content appear to have a small protective effect in rheumatoid arthritis. Small, for some people, it might be good to have. But in menopausal women, HRT reduces the risk of ACPA positive RA, but it does not affect the development of ACPA negative RA. So the genotype and the omics type is very important. Not all women will benefit from adding HRT to their treatments. In established RA, the use of HRT does not increase the risk of flares, which we said are happening after menopause. If you look at patients with ankylosing spondylitis, usually there is an improvement of peripheral arthritis and clinical activity with estrogen replacement therapy. When we say estrogen replacement therapy, we mean only estrogen replacement therapy when you don't have a uterus. If you have a uterus, estrogen replacement therapy means supplemented with or combined with progestins. So you don't create the problem of endometrial cancer. So only estrogen to women, only to women without a uterus. If you have a uterus, the situation gets more complicated. And in systemic lupus erythematosus, the use of HRT has been linked to an increased risk of mild to moderate flares. Let me see, finish there, and then I will add an important comment. As in the general population, the use of exogenous estrogens increases the risk of thrombosis. Imagine if you had antiphospholipid syndrome or antibodies, then it gets very difficult to take a decision to treat or treat. So women with SLE that are seropositive are not allowed to get HRT. And then if we have perimenopausal or menopausal symptoms, we will choose other treatments, not as effective, but safe. So bear in mind this also, the problem and the risk of thrombosis. In women with Sjögren's syndrome, which have many, many problems with sexual health due to extreme vaginal dryness, we have tried to supplement with vaginal DHEAS, one form of male sex hormones, but it has failed to produce clinical benefits. I have many women coming to my practice, especially women living over here that might end up in Thessaloniki. I come from Thessaloniki, and speaking amongst them, they say, "Oh, my physician gave me." One came to me actually bearing a handwritten note. "Oh, they give me testosterone and stuff." There is no data that exogenous supplementation helps terribly, even in patients with low serum DHEAS levels. And this is actually another problem I have, because many patients come to the office and said, "Oh, please measure my hormones." We don't need to measure everything all the time. We don't get clinically important data in this situation, at least. So when asking about being examined, you need to ask for the correct things, not for everything, or something you heard from your pals. And HRT, here, this is the important thing, because pulmonary hypertension is a serious, a deadly and serious condition in women with systemic sclerosis. They might benefit in the limited form of the disease. What is the problem with hormones? The problem with adding HRT, in my opinion, is not just the effectiveness and safety of adding HRT, is when you have people with underlying medical conditions like patients with RMDs are, you need to consider also what we call polypharmacy. It's a problem of using too many medications at the same time. So when we add something in somebody's pharmacological therapies, we need to consider also the total number of medications they are using. It increases the cost, it increases the risk of complications, it increases the risk of interactions. Some drugs may work more strongly, others less strongly. And using more than 5 medications at a time, it's a definition of polypharmacy. 5 and more medication, it increases risk for any kind of patients. So we might be doing harm than doing good. So bear also this in mind, and that's why patients with RMDs are special and very interesting, of course, but special and difficult type of patients because of these complicated therapies and the need for many medications at the same time. So to optimize pharmacotherapy means we really need to think and specialize and personalize. So it's very important to bear in mind and not pressure for getting more medications than absolutely needed. So I will, and we are finishing in a few minutes, so we can go on with the panel group discussion. Osteoporosis is also a problem. And in patients with RMDs that already have serious bone and synovial tissue problems, it's something that it's of concern because it's a condition associated with AIDS, but also it's a condition caused by many of the medications used to treat, especially glucocorticoids, to treat RMDs. So if you add primary ovarian insufficiency or early menopause, and then RMDs, you might end with more pronounced osteoporosis and osteoporosis occurring earlier than in the general population. So osteoporosis and bone health in general is also something that should concern patients with RMDs. So in female patients with RA, the risk of postmenopausal osteoporosis is twice as high as compared to age-matched women without RA, 50% more. It's very significant. And also the presence of ACPA, these antibodies has been shown to be associated with reduced bone mineral density independent of disease activity and other confounding factors. So having an RMD, being especially rheumatoid arthritis and being ACPA positive, it's a bad thing for osteoporosis. So even low doses of glucocorticoids in prolonged use will exacerbate the problem. It's actually an important and significant risk factor for severe postmenopausal osteoporosis. They both inhibit bone formation, they increase bone resorption, and they reduce calcium absorption. And then comes the big question, should we supplement with this or the other and the other? I have bad news. Calcium supplementation, even with vitamin D intake, doesn't look like it helps. And I hope nobody here is a pharmacist. My brother and my father are from, one of my brothers and my father is a pharmacist, actually commercial pharmacist with their own companies, but, and they sell these things, and many people buy supplements like crazy because they believe that in buying all this calcium and zinc and vitamins and minerals, whatever else, will help them become healthier. But I'm sorry to say that eating properly, it's much better than supplementing with this, even the best of these supplements. So it doesn't help very much. So we have limited data, but an increasing number of studies that have explored the role of sex on the immune system. There is a considerable amount of evidence in the literature nowadays suggesting that estrogens play a significant part in autoimmunity. However, the impact of menopause to RMDs, basically, we kind of have very limited data in general about patients with RMDs, although it's a quite big part of the population that has these kinds of problems, and they seem to be increasing, at least when you listen to people complaining about that. And we should invest more on studying what menopause causes on RMDs, because this actually it's an ideal natural model to understand how hormones impact the immune system and the clinical phenotypes in rheumatic and musculoskeletal diseases. And remember, in red, so we remember, all of us remember it, menopause can induce the development of autoimmunity and can alter the course of immune rheumatic diseases. sometimes improving disease, but in other cases worsening it. And it's for many of you, it's bad enough to begin with. So we definitely need to do something and be prepared, have some strategies, if not pharmacotherapies, other strategies to help people affected. So thank you for your attention, and we'll go on. Yes.
What about what about if the menopause come not normal after hysterectomy?
It's the same.
It's the same.
It doesn't matter if it's surgical or if it's natural primary ovarian insufficiency. The only problem, or no, not problem, the only difference between surgical and normal primary ovarian insufficiency is the way they come. It's more, how do you say, it's more abrupt when I remove the ovaries than when the ovaries die prematurely themselves.
So an osteoporosis case is the same.
It depends on the age. It doesn't depend on when it happens, how it happens. Okay. So the earlier,
the worse.
It's the worse. But also, it's a question of what has happened until you are 25. So people exercising, building better bone, and having strategies up until 25 and after 25 until menopause to protect their bones and work on them, they fare better.
Okay, thank you.
Thank you, Dr. Sardelli. I have one question also, if you please. We are taking a lot of medications, not only pills, but special medications, for example, biological therapy. What do you think, is it possible to have hormone therapy while you are on biologics, or it's too risky?
No, you can. It's not a problem. These medications work in different ways.
Yeah.
Hormone replacement therapy goes, especially if you're talking about estrogen progestins, they go and work on the specific sex hormone receptors. The biologics work on the immune system. It's a different thing. You can have it together.
Yeah, I know, but I'm talking about the risk of cancer that we know the biologics have, and the risk of cancer that hormone therapy have. I also had a talk with a colleague, your colleague in Bulgaria, and the doctor told me, no, hormone therapy is not okay for you. You have to have in mind that you're on biologics. You have to check your cholesterol levels, and etc. etc. I can't bear the risk to prescribe you hormone therapy.
No. I totally disagree with this colleague, because when you become menopausal, your lipids go up, your cholesterol goes up, LDL goes up, HDL goes down, and we know that estrogen and progesterone therapy help with these things. We also know that the cancer risk from HRT is over-exaggerated. If you start early, if you keep the dosages as low as possible, and you keep it in a limited amount of years, I would not say 2 or 5, I would say the least amount of years, the least number of years that a woman needs these medications, then it's okay to use it. Of course, you need to invite the woman in for regular checkups. I'm not asking about regular checkups every month. This is crazy. But once a year, have a total body workup, it's fine. But HRT, there is a very limited increase in cancer risk only for breast. There is no other risk about cancer. Biologics, okay, because of their immunomodulatory function, they might increase in some patients the risk of specific cancers. But these patients, actually, if I am allowed to say that, they become cancer patients because they are genetically predisposed. It's not the medication in itself. And of course, as I said earlier, personalized and And one size does not fit all. You need to look at each individual personally and take decisions after discussing numbers, not saying, I will not take the risk of that. It's not good.
So it's better to have more opinions, to visit more doctors if we
Or
need.
at least ask this doctor to explain the numbers so you can make an informed
No.
decision.
She can't explain. Because I'm president of the organization in Bulgaria, we have a lot of questions. That's why I wanted to know what to tell people if they need to visit another doctor or it's totally unsafe for them.
Which kind of specialty does the specific physician you're talking about have?
Gynecologist.
Gynecologist obstetrician.
Yes.
Well, as I told you, my colleagues, because of the WHI study in 2001, many still believe it's not allowed to use. And by the way, when we are discussing HRTs, what is the most terrible thing happening? Because of this study, they are not, many physicians are not even prescribed vaginal estrogen because of the perceived cancer risk. It's zero. It's zero. Okay, systemic use, and especially patches, which increase the risk for thrombosis, I would also think about twice, not say no, think about twice, but about vaginal estrogen, which helps not only with the sexual health, but also with total physical health. It reduces the risk to develop a severe genitourinary infection, which in very old women and sick women, it might even kill. Yes, a cystitis might kill you if you are old enough. Yes.
Sorry, just something you know that because you are obstetrician gynecologist and also you're a professor of clinical pharmacology, so you have the knowledge. May I suggest something? Maybe to Boriana, maybe they will be, as association, contact with you if you have the time to ask some questions because you have the prevalence to be both.
Yeah, I'm
if
absolutely.
it's
Please
possible,
send
this
me
is-
things. I'll be happy
Okay.
to help. Also, come and visit also if you want.
I will be
at some
happy.
point, yeah.
Next year, the Agora conference will be in Bulgaria, so we can prolong the the
You have
topic.
invitation from
Thank
now.
you so much. I'll come. Yes.
So, do you hear me?
I'll just go get some water. But
Yes, yes. So I just wanted to say something about the HRT therapies, and there are recent studies, as far as I know, concerning the vaginal estrogen creams and supplements that might even be safe for breast cancer patients as well.
They are safe.
If they're safe, I can get them too.
Safe.
Okay.
Use it.
For breast cancer patients,
For anything, cancer patients.
well, I'm a breast cancer patient, okay? And they deprive me from this opportunity. But I'm reading in recent
There
studies,
is more
but yes.
and more research data saying it's safe. But as I usually say, it's your body and your decision. It
If
depends.
it comes to us, we'll say no.
Well,
No, it's
if you
fear.
say no, then it's not my problem. But it is safe, and you will tell us how burdened you are from your genitourinary problems. But if you are burdened from these things, use it. If you are not burdened and you feel like, oh no, it's okay, maybe I don't, but it's not risky.
Well, I've just heard the word I was kind of expecting to hear because menopause for women, it's kind of a new era in their lives, and fear is a predominant feeling. And when decisions are made upon fear, I don't think they're correct.
No.
And when fear is accompanied by lack of knowledge or information,
It becomes worse.
then it's even worse. So I think that, and this is something that preoccupies me. I have the lived experience of surgical menopause, and I've been under HRT, and now I'm done with it. But I've taken like it's for 11 years, and things were explained very meticulously, and I made the decision, like myself, to be under the HRT medication for 11 years. So when things are not explained, and also applies to the RMDs and goes back to the communication between yourself and the physician, always back to the communication and the trust or lack of in the relationship with your physician. So it's all a matter of things happening when you do not explain or you are not like thoroughly in knowledge of what's happening and what is about to happen, then you are afraid and then you don't know and then you probably will make the wrong choice for yourself. So as you said, things are safe or as safe as they can be
As safe
because
as they
they
can
are,
be. There is
yeah, they
nothing
are
absolutely safe
medication.
in
Yeah,
life.
I
Okay.
know.
Yeah, yeah.
But we're talking about medication, as safe as they can be, yeah. But you need to be able to make the choice for yourself, whichever choice that is.
Yeah, yeah. But she said, I'm sorry, I didn't get your name.
Yeah.
But Emily. Emily said, Eleni said, if anybody speaks about even the smallest risk, I will say no, because I'm already a cancer survivor. It depends on how you look at it. Most of us will become cancer patients during our lives. It's one in five right now. 20% of us will get a cancer during our lifetime. So we cannot, when we survive more and we get it earlier and there is better treatments, but you need to live the rest of your life. So if something is safe, I would compare it to as safe as ibuprofen for pain. It's so safe to use vaginal estrogen. Use it.
Maybe this is the same case when we started using biologics. I remember that time. I used biologics for 15 years now. And I remember in our organization, people were afraid because in the leaflet it was written a lot of side effects, including cancer. And then I said, okay, I take the risk to have cancer, but I want to live normal life for these 15 years as it happened. So maybe here is the same situation. When we are informed, then we take the risk because we don't know what will happen, but we have to live normally because, as we know, menopause is something that is very, I don't know, it's stressful, you know, the moods, the sweat, everything. And as Nadia is psychologist, I would like to mention something else. In our country, I suppose that in other countries from our region, women are not used to talk about such topics as menopause, sexual life. I don't know how it is in more developed countries, northern ones, but in our region, it's not common. You have to work, you have to take care of children, but not to talk about menopause. It's something normal, you will go through it. I hear this from my friends also. So,
Well,
this is the other side of the coin.
well, I'm a woman myself, and although I tell everybody I will remain 30 forever, it's a medical reason why I say that. I will explain this. They come to my practice, and some people add years, some people hide years, some people overextend, and I hear many patients saying whatever they want. So I decided I'm 30 forever. Just because they say whatever they like, I will say whatever I like. But okay, I'm 53 years old, and I'm exactly 1 year after I'm in real menopause myself. I would say I'm lucky as a woman. I don't have so severe problems. Maybe some sleep disturbances, and a couple of times night sweats. It's nothing. It's nothing. I don't feel like discussing it. I don't feel the need to discuss. I'm in menopause. I do not sigh from saying it, but I don't feel the need to discuss it. Okay, I'm knowledgeable as can be in this situation, but it is a normal situation. It is the normal progress of life. I would prefer we say it's a normal situation until it isn't. Because we shouldn't over medicalize it. But for those that are in distress, yes, we need to give help. We do not talk so much about our sexual experiences or our reproductive experiences with other people. Yes, but do we really need to discuss so much about everything?
No.
I believe we are in a situation where we came from not talking about women to trying to get to become very, very visible. It will come to an equilibrium at some point. But I'm all for discussing if it helps promote our rights.
Yeah.
But let's not
No.
exaggerate.
The reason
Yeah.
why I said this is because women are not ready to talk even with doctors
Yes,
when they
this is a problem.
experience
This is a problem.
those flashes, whatever, and they are
is a problem.
hard. They are not ready to talk with the doctor about this. They say, okay, it's normal. I will try to manage, but sometimes it's hard. So when it's hard, you have to talk with the doctor. That's the reason I said it. Nadia.
Well, I have to just I'm agreeing, but I have another point to raise in terms of discussing. It's kind of it's one thing to discuss whether you choose or not. This is a choice. It's another thing because of cultural or social um, demanding or like social
Constraints,
or
yeah, yeah.
constraint
Yeah.
or trend or whatever. It's another thing to hash it out
Yeah,
or
yeah.
not
I'm not
being
talking
able.
about that.
Let me
Yeah,
just.
yeah, yeah, yeah.
A menopausal woman might be, again speaking out of experience, might be having hot flashes in her working environment, like many hot flashes
Yeah, yeah.
throughout the day, because not all of them have only night sweats. So imagine that woman being working like a working woman and like living in that aspect and being amongst her colleagues and having someone call her out just because of that. This is stigma. This is a very weird case of racism, and this needs to be called out, and this needs to stop, and this really happens.
Uh,
So that's
I don't disagree. And
yeah, yeah.
there is
So
more stigma.
that's one thing we need to be able to advocate for. So one thing. So that also is for the women in a reproductive also phase of their lives when they have their menstrual periods and they go to work and they are in severe pain because probably they have endometriosis or something and they are in pain. This also needs recognition, validation, and destigmatization. So these are all issues that we need to call out and be able to talk about. So I'm all for what you said, but also to think about the rest.
No.
Yeah.
Do not misunderstand me.
No, I don't.
I
agreeing
propose
you.
something different.
I'm agreeing with you.
I propose, I'm beyond destigmatization. I advocate that you just, if you have a need, just say it, but not not exaggerate. I'm having hot flashes and I need a regulated temperature in our workspace, period. We don't need to dramatize it. No, I agree with you, and there are crazy people like around. I will not say men only. Women do that to each other. About women with periods and women with having children or not having children, and women with yes. So yeah, yes.
Because we are doing that together. When we're facing that problems, and I'm not talking as Hellenic Monopause Society, I'm a member of the board. When we start working on that, and we're going to the suburbs, not in Athens or in Thessaloniki, where none of the women decided to come to our events because they're afraid not to say that I am a menopause because now they're going to be they will be consider me as an elder. So this is another problem. And
You're there
when we
forever.
go from other countries, like in other cities in the suburbs, and we have events there, you will see the difference between when they came the women and when they left the women. And when we have decided to replay, to do it, to repeat that, they say that the women now they know they don't be shame to say that I am 53 or 50 and I'm striking for menopause. And when we talked, and especially Chrisa said, speak to your doctor. If you have a problem, speak to your daughters and don't be like a children having do you know I'm having something, asking for something.
I don't know about what it is, but
Yeah, but this is very, very important about the awareness. This is important in that things, and this is, I think, where we can, with our association, not as Hellenic Menopause, but as RMDs associations, as
yeah, but you know
whatever.
what? I'm having in the last months, I'm having a crisis myself as a physician. Although I'm 30 years of age, I'm almost 29 years a physician. When did this time pass? But all this time passed. But I'm having a personal, professional crisis. I'm not so happy to go to work anymore because I seem to be facing patients unable to understand what I'm saying, and I haven't changed. I'm using the same words all these 29 years because I'm trained in communication and everything. So I'm not sure when it starts. Or maybe I'm tired. It's a tough job to be a physician. Okay, but the patients have changed a bit. They want results immediately. They do not want to, although they are not telling you the truth always. So you need to fish it out. What is the main problem? And when I'm asking, what's your problem? They believe sometimes that you are too direct. And we need to get a result here. So it's a fine equilibrium, fine line between being professional and giving results and giving space and time. But yes, you shouldn't be afraid to ask for help. But you need to think before coming to the doctor, or not the right questions. Tell us what is the problem. I will tell you a story about a menopausal woman, if we have some minutes later, which was crazy many, many years ago. Yes.
If no one says that, there is someone between yourself and your patient. Do you know who that is?
The priest.
No, no. Yeah, in some cases, maybe. Why not? But there is absolutely someone between yourself and the patient. It's called Dr. Google, Dr. Instagram, Dr. TikTok, Dr. Facebook, and Dr. ChatGPT, who is the
Yes,
absolute
but
best of all.
I'm called the mistress for obvious reasons, and I cut these things. No, okay. Yeah, it's a terrible thing, and it's a terrible. Maybe we have time to. I have a comment to make. My special focus in reproductive medicine is the use of medications during reproduction. So, last week we had the conference. I was chairing the conference of the European Network of Teratology Information Services. Teratology now is called reproductive toxicology. It's not so nice to speak about monsters. So we had our conference last week in Thessaloniki. So we have a big problem with this, with EMA, about the leaflets in medications and all this safety information and in general. I don't know how the EMA, the central organization, the CHMP, the Council of the representatives of the European countries who are deciding upon which medication will come to market, but also the PRAC. PRAC is the Committee on Medication Safety to Adverse Events. They end up with these black box warnings, and they end up with this information based on ridiculous data and misinterpreted data. So don't be so, and we have a serious trouble to speak to the EMA and change these leaflets. They don't do it, they refuse. We work on it when it comes to prenatal care and pregnancy care. We have terrible problems with that. So we registered our organization in order to become an associate of EMA, in order to have a say in things. But I'm not very optimistic. But that's why you need to discuss with physicians informed. And actually, I don't care that I have this dual specialty, obstetrics and gynecology and clinical pharmacology. When you prescribe medications, you need to know the data. I'm not special. They should know the data.
Most of the doctors don't read the data, and most of the patients, they don't believe because they are afraid of the leaflet. You said, I can understand. Others in the room can understand because we are leaders in our organizations, and we read a lot and we have a lot of information.
Yeah,
Not
it's
as much
obvious.
as you,
Yeah.
but the other patients, the regular patients, they are not so informed. So I'm not sure that I can explain this to them. Maybe a specialist like you can explain that.
Don't tell them, at least, don't focus so much on the leaflet. Read the leaflet, ask your questions to your physician, but not focus only on that. And fear, like Nadia said, fear is a huge thing. But I have no other instrument about fear, combating fear, than saying what happens. Okay, people don't believe me. That's why I'm a bit tired these days and feel like a failure sometimes. But it is what it is.
It helps sometimes when we exchange experience. I see it with the biologics. When people say, I feel good, I feel better, I don't have side effects, so the others are more willing to start treatment.
I'm okay with this, but in order to share positive experiences. But sometimes they come to the practice and say, oh, my mother had this and she died. The lady next door, the neighbor, had this and they died. And actually the neighbor had something totally different or did something totally different. So don't share the medications. Okay, so, but it's important to talk amongst ourselves. We shouldn't be shy about it, but let's not make it a huge deal. I see two gentlemen in the room. Do you guys maybe have something to say about menopause? There is also, and four guys over there looking, pretending they don't care. So there is 6 guys in the room.
I experienced it. I experienced it because obviously my ex-wife and now my partner living in that condition.
It happens to everybody.
When they are in that period, go far away.
Really? You too. Yeah, there is an andropause, guys. Don't think you don't have it. It's actually worse for them, because of... and for us, it's not a problem. It only takes vaginal estrogen.
Can I ask
Yes,
you
please.
something? From your experience, is there something that patients from with or without RMDs need to ask their obstetrician and do not? You
To ask.
to ask, yeah. You have the answer, you wait the question, but they never do it, and you have to say it yourself.
No, usually I prepare a speech saying everything. I have a speech for young girls. I have another speech for women in childbearing age. I have another speech in premenopausal women. And I have another speech for postmenopausal women, but that's me, I'm very prepared. But because many times, yes, and I catch myself speaking. Yes, the stupid thing which I feel terrible about myself is when I say things in diminutive. I'm not saying, "Oh, please lift your leg." I say, lift your little leg and then move your little butt. And it's like, I'm saying, how am I addressing this person? I mean, it's like, I hate myself, but we put it this very, very sweet thing as if it changes. But no, I'm not, I have my speeches. But I believe that, I believe there is a question, is that everything? I mean, take a minute before leaving the practice to think and then ask doctor, sir, madam, is that all? Is there something I should be more careful about or paying more attention about it? A question like that, I would say. But okay, for women going to the physician, either irrespective of its primary care physician or obstetrician gynecologist, I would ask, when do you need me to come back? And when do you need me to come back? So.
Thank you very much. It is a really interesting topic, but we don't have more time. I'm
Thank you. It
sorry,
was,
so we have to finish, but it was really interesting.
Thank
Thank
you
you
very
very
much.
much.
I will be back later.